I think that after the surgery we can have a discussion about that case. I think that it can help us a lot, but I think that the best solution is to wait until they finish and they take care, and then we will have a discussion about the case. Now I will continue with the quadral lesions. So I will focus in that talk, and then we will have the discussion about the case. When we are treating hip problems, when we are doing hip preservation surgery, when we are doing hip arthroscopy, we know that some cases fail, even if we do a nice surgery, even if we are doing a proper intraoperative impingement test and we see that there is no problem, even if we are doing what we have planned in the way we have planned, sometimes we have pain after those surgeries. And Clogy studied why do hip arthroscopies usually fail? And he concluded that as other studies conclude, that probably the problem is related to the cartilage. So when you have a cartilage lesion, even if you do a good surgery, you could have some residual pain. And what is more important, you are probably not changing the natural history of the degenerative joint disease. When we are doing this kind of surgeries, we must have in mind two important things: the symptoms of the patient, but also the natural history of that disease. With our procedure, are we going to solve the problem of the patient? Are we going to solve the pain of that patient? But another thing, are we going to give more years to that joint? Are we going to change the natural history of that problem that will lead to an arthrosis and to a prosthesis? And those things must be in mind always. And the problem with the cartilage lesions is that probably we can solve part of the pain, but not all. But there's no evidence that we will change the natural history of the disease. And that's a very important term that we have to have in mind. Other studies like that made for O'Donnell in Australia, he said that the intraoperative cartilage degeneration predicts the outcome 12 months after hip arthroscopy. So the outcomes of our patients, if they have this kind of articular lesions, will be worse than if the cartilage is okay. So it's the main thing that we have to have in mind. If there is a cartilage lesion, we have to advise to our patients, probably I will not release all your pain, and I don't know if I will change the natural history of your hip. And that's, I think, it's very important. And the problem with the femoroacetabular impingement, especially if there is a cam lesion, is that these cartilage lesions that we can see in the magnetic resonance are always bigger when we do the surgery than what we expected. Because of this delamination, in the magnetic resonance we can see in the very periphery, but when we advance, we see that it's a huge part of the cartilage that is unstable. It has been treated, and the literature says that it can be treated by microfractures. And probably it's a good solution for the limited areas of cartilage defect. But in a bigger area of cartilage defect, probably it's not sufficient. This paper from Griffin said that the microfractures for acetabular condyle defects in patients in the second looks were not very good. It's not always completely filled by fibrocartilage, and it's not a really good solution in the hip as we thought it could be. So we must be very aware of doing those very big resections and thinking that with our microfracture we are going to solve that problem. So what can we do with those chondral lesions? What do we have? If you go to the literature, there are papers about everything, with chondrocyte implantation, with any technique of bone marrow stimulation, Mathy techniques, and reparation with tissue adhesive or chondral sutures. All of those are possibilities that we have to try to solve that cartilage. But I have to say to you that there is no clear evidence on any of those techniques. So that's something that we can do because there's no solution, but there's no evidence or good evidence on any of those solutions. If we try to see what is the evidence-based medicine and we go to the literature, we found just two techniques that probably have the best level of evidence. They are studies with level evidence 1. This is the bone marrow stimulation with the BS sticker gel. That it's an implant that tries to make a stable clot. And this is the technique with the chondrocytes. Both of those techniques are for the knee. There is no study in the hip. And even they have a level evidence 1, it's a very, very low quality of studies. So it's not something that you have to say, well, there's a level evidence 1, I have the solution. No, it's probably probably the best solution that we have nowadays, but it's not a good solution for chondral lesions. You have to have that in mind. There is no real solution in the chondral lesions, but we have to do something. So what can we do? What can we do, especially in the hip? Well, if there is a small limited lesion that probably can cause some kind of mechanical problems, I think that the best solution is trying to remove that cartilage, trying to remove the unstable cartilage in order to not produce any mechanical problem, and leave it away. Do nothing else. That's what I did yesterday with the very small limited lesion. I just take it out in order to have a mechanical stability, in order to avoid any kind of blocking or a progression of that lesion, but nothing else. The problem becomes when the lesion is bigger than that one. If it's limited like this one, probably with the debridement it's enough for the mechanical problem, but not for solving the long distance or long-term results. In those cases, I like to do microfracture, and probably it's enough in those very limited lesions where you can achieve some kind of fibrocartilage that will give some stability to the rest of the cartilage. Microfracture it's not an easy technique in the hip. You must train in the cadabra a long time for doing those techniques, because the instruments do not go perpendicular to the cartilage lesion as you do in the knee. You go tangential to it, and it's very difficult to make really good technique. The technique means that you must do a proper debridement of the unstable cartilage until you find stable cartilage, and you must find really stable cartilage. That means that you must increase the lesion, sometimes a lot. Then you must debride the mineralized layer, and you must be very sure that you have eliminated that mineralized layer. Otherwise, you are not doing microfracture, you are just doing holes. And after that, you must do holes. And holes in the hip, if you go tangential to the acetabulum, it's very difficult. It's very difficult because when you push with the hammer, you do rails more than holes. So you must be very careful doing those techniques, and you must practice a lot before doing it in our patients. Sometimes you must detach the labrum in order to be able to go under the labrum to do proper microfractures in the periphery. So you have to do that. And then you have to repair the labrum. So you must have in mind, am I going to leave a more stable hip? Am I going to have a better hip after doing that? Otherwise, do not begin with the attachment of the labrum. So after the microfractures, if you have to go under the labrum, then you have to reattach the labrum in order to leave a stable labrum. But sometimes when you have this chondral delamination and you look after an unstable labrum, you find things like that. It's a huge cartilage defect. And how to solve this? Do you really think that just with microfractures and giving some kind of fibrocartilage will solve the problem? It's difficult to think that it's like that. The microfractures are well done. Theoretically, we have done what it said that it could be done, but I feel that this is very difficult for me to think that this will heal that hip. That's why we are looking for other options. Maybe that BST cartridge, that implant that can stabilize the clot, will give us some solution. I still don't know. I began to do that 1 year and a half ago. I still don't have cases enough to say, yes, that's a good solution. We are following those cases with the degenerate, that it's a magnetic resonance that can measure how much cartilage do we have and the quality of that cartilage. And probably we have to wait a few years to see if this was a good solution. But that's what we do. For example, that case where you can feel that it's a normal hip with that huge cartilage effect. Here you see the cartilage effect with a labrum unstable. So here, what I did after the proper debridement, and I will stay here for a while. A proper debridement means that you must take all the residual cartilage and you must take a bit more. You must find healthy cartilage in the borders, otherwise your technique will fail. So as you can see, it's an aggressive technique, but if you think that it's the best solution, it's what you have to do. It's not a good solution to say, well, I will do something less aggressive, or you go or you don't go. And if you go, you have to go like that, taking the debriding properly and then taking the mineralized layer, and then you can begin with your microfracture. Looking at the stable bone. Then you must perform your holes. They must be 3 millimeters depth, 3 millimeters apart one of the other. Now they are studying the possibility of doing nanofractures, that it's going back to the initial pre-D procedure, where we do very small, thinner holes and more large ones. Probably it will be a good solution, but we still don't know. So I still doing microfractures like that, trying to avoid doing canals, just holes. If there is an area where I cannot do a proper hole, I prefer to do nothing, but not doing a canal, that for sure will lead to the creation of an osteophyte that will be a bad solution. And as you can see, it's not perpendicular to the acetabulum, so it's not easy technique and needs to be practiced. When I do the refixation of the acetabulum, if I can, I try to take some kind of anterior wall in order to have a smaller area of chondral defect, like here. And the implants must be very close to the edge in order to have a stable and contained chondral lesion. As you can see, always you can always translather, as we saw yesterday. So finally, you will have a stable labrum and, what is more important, a contained chondral defect. Now here I'm treating the cam lesion. It was a cam femoral impingement, so now I'm treating the cam lesion. And after that, I will take the fluid, I will dry the joint in order to be able to put the implant. Here I'm taking the fluid down, so it begins to bleed. That's good. And I have to have a completely dry joint. Here it's completely dry, or it's being dry. And then I put the implant, that is the BST gel. in order to have a clot Is that going to heal that contra lesion? I don't know. I think that it's a better solution than microfracture, but I don't know. I'm presenting here because we have those problems and we don't know how to solve them. And probably that can go in a good direction, but there is no evidence for that treatment. Be careful of beginning to do that, thinking that you are solving the problem. Probably it's a good direction, but we still don't know. The post-operative must be very careful. When you are treating any cartilage repair technique, you are always thinking in 1 year follow-up, in 1 year rehabilitation. That means that during the first 3 months you must be very careful. I have done patients 6 weeks with just 2 bearing, and then 6 weeks more with partial bearing, and then I have a very, very slow post-operative rehabilitation. And I think, and I always explain to my patients, if you are going to do that technique, you must think that you have to be aware of, you must be careful with your hip during 1 year. Do you think you can do it? If they think, no, I can do that, then I go to another technique. So I think it's very important to do that to patients that understand what they can expect from their hips. That's why I think that this indication is for very young people who are really aware of what is going to happen with their hips in the long term.
How much time do you wait to
Excuse me?
How much time do you wait to solidify?
It's 50 minutes. It's not a long time. It's something that you can do easily. Technically, it's not difficult. The problem of that technique is what it will happen in the long term, what it will happen with that hip, with that cartilage in the long term. You need patients that understand that they are doing something that there is no evidence, that probably is a good solution, but we still don't know, and that they want to invert 1 year of proper rehabilitation. Yes, tell me.
Does this car gel need microfractures?
Excuse me?
The car gel needs microfractures beneath
Yes.
it?
What is the BST is? What is the stand for? BST?
BST is the name of the product, is BST cartel. Usually, in the first steps of the femoroacetabular impingement, we find that there is unstable labrum, but it looks sometimes pretty healthy. What can we do without the lamination lesions? Because if we debride, we will find a hole like the one that we have just seen. So if we leave like that, it's an unstable cartilage that it will progress. So what can we do without the lamination lesions? What it's said a pocket lesion, where you can open the cartilage, but it's relatively stable. We have examined those cartilage, and we found that there are normal cartilage in it, normal chondral cells. Biller studied that also, and he found exactly the same. David Griffin also studied that and found exactly the same. So in those delamination areas, the cartilage has good chondrocytes. So probably it can be a good idea trying to make those unstable cartilage lesions stable. That's what Richard Biller tried to do, putting fibrin glue between the bone and the cartilage. It leads to a stable cartilage effect, and you don't have to resect. I'm not very sure that it's a good idea putting anything between the cells and the matrix layer. So I tried to do some kind of mechanical stabilization, but without putting anything. That's why I begin to do those sutures translateral in order to give some stability, some mechanical stability, as you can see here. Just doing some kind of outside-inside sutures in order to just give some stability. You see, in that lesion, if I go with the debridement, I will have to debride all that area. It's a big one. So So I try to preserve it. I try to do those sutures. It's not easy because the cartilage, you know, it's very difficult to suture. But giving some kind of stability. We have done some of those cases, more than those, but those are the ones that they have a good follow-up. And we saw that, well, the outcomes are good, but this is nothing new. The outcomes are good because we solved the femoral acetabular impingement, because we solved the chondral lesion, because we treat the labral lesion. So the outcomes are not related to the cartilage. Because the problem related to the cartilage is something that we will find in 5 years or in 10 years, but not today. Probably for finding in 2 years follow-up a good solution, you just need to take to do some kind of stability to that chondral lesion. So probably with the debridement you will have the same results. But what is very interesting is that the discernic at 12 to 18 months show normal cartilage, quantitative and qualitative. And we have one second look. That second look was related to a patient where I did something that I think is not a good idea. I put something. That second look was related to a patient where I did something that I think it's not a good idea. I put an anchor, and with the same anchor I tried to make the suture of the cartilage and the labrum. And it's not a good idea because the labrum must be reattached firmly in order to have a very stable labrum. And the cartilage must be reattached very softly in order not to destroy the cartilage. So here I did the suture very softly in order not to destroy the cartilage. So I was aware about the stability of the labrum, and I did a very slowly rehabilitation program, avoiding the movements during the first month. And that leads to adhesions between the capsula and the labrum. So that patient at 1 year post-op, when he begins to swim and he begins to do more exercise, he begins to have problems in the internal and external rotation. So I did a second look. In that second look, I saw the adhesions between the capsula and the labrum, and I I take those adhesions away. But what is very important is that I saw that the chondral lesion, here is the chondral lesion, that chondral lesion looks at least in the same situation. There is no progression to degenerative of that cartilage, and it was stable when I put the probe inside. So, and the generic was showing that it's normal cartilage. So I think it can be a good solution for those cases. And that's all what I wanted to explain you about the chondral lesions. But remember what I said at the very beginning. There is no good solution with a good level of evidence. Be careful when you decide what to do with those chondral lesions, and be sure of what you explain to your patients. What can they expect from those chondral lesions? That's something that probably is a good solution, but we still don't know. Thank you very much.
Thank you, Professor Mark, for this nice presentation. If you have a case of partial thickness articular cartilage defect, so which is better, to leave the remaining part of the hyaline cartilage, because the hyaline cartilage is a very precious tissue, and just you remove the overhanging fragment and that's it, or you remove the remaining part of the articular cartilage and you do the microfracture, and as we know, the results of microfracture at best is fibrocartilage and at worst is fibrous tissue or nothing.
You have to go to the cause. Which is the cause of your chondral lesion? Is it related to a mechanical issue like thoracoacetabular impingement, or is it a degenerative one? If it is a degenerative one, I think that anything that you will do, it will fail. So just give some stability. If it's related to a mechanical cause, and you solve the mechanical cause, like those lesions that were related to a femoroacetabular impingement, I solve the femoroacetabular impingement, I take out the cam lesion, and then I have the control defect. But if it's a mechanical cause, you will never have a partial thickness cartilage effect, because the cam lesion what produced, the shear forces what produced is a delamination. You always have a detachment of the cartilage from the bone. You saw that it was normal cartilage, but just off the subchondral bone. And that's why I'm solving the mechanical problem. But if it's a partial thickness, that means that it's related to another thing. It cannot be related to that lesion. If it's a partial thickness lesion, it's related to an overuse, it's related to the degenerative by other causes, it's related to the age, but not to a mechanical cause like this one.
Yes, thank you, Dr. Mark. Very interesting elaboration on different ways of dealing with this. Now, obviously, it's a very nice comment to a very intelligent question about probably how we differentiate between a mechanically induced cartilage lesion versus a degeneration is by simply this. If it's a partial wear and tear, it cannot be mechanical, it's probably degenerative. And if it's mechanical, it has to be some form of a full thickness mechanical trauma. That whether it's a chronically induced small trauma, like an impingement or a massive trauma that completely shears off the cartilage of the trauma. My question is, and it's a bit of a comment as well, is that I think this reattachment of the cartilage matches well with our knowledge about the pathology and the physiology of the cartilage, because basically when you detach the cartilage, you're detaching it at the tight mark of the cartilage. This is where the cartilage probably gets detached, isn't it? And the cartilage itself is a tissue that does not need any blood supply. It just needs to be reattached back to the bone, and it receives all its nutrition from the fluid, the synovial fluid. So if you have a full thickness cartilage, like Uki Villa showed on the slides that you showed, then probably it makes much more sense to reattach the cartilage, because it's a tissue that can still function, and the chondrocytes will survive if you provide them with a mechanical stability. Now my question is, what is BST? What does it contain? What is its structure? The structure of BST that you use.
The structure of the BST. Well, I have to say that when I can, I always reattach. I just go ahead with the microfractures and the BST when it's not a pocket lesion, but it's a flap. That mechanically I cannot reattach, or macroscopically I see that it's degenerated. If macroscopically I see that it's it's not normal cartilage, I don't go ahead with the reattachment. But especially in those like that, the one that you saw, that it's a flap or it's a defect produced by the mechanical cause. Those cases I go ahead with the macrofracture. The BST gel, it's something that is based with the chitosan. Chitosan is a protein in the shrimps, I think, something like that. And it's mixed with blood. And they have a study, a nice study in me, but it's a nice study where they saw how that implant promotes some kind of stability to the stem cells that came from the microfractures. So the idea of the microfractures is that you make those holes, then it came some stem cells from the chondral bone, and that stem cells will produce some kind of cartilage, sometimes fibrocartilage, sometimes hyaline cartilage. The BST gel, what it produces is some kind of stability to that clot, and it increases their properties in order to produce hyaline cartilage.
And it dissolves after that?
Excuse me?
Does it dissolve after that?
Yes. That's what they prove in their study.
So actually,
They solve the control defect and they produce hyaline cartilage. That's what they demonstrated in that study in the knee. And I have to say that even if it's a legal evidence one, I think it's a very, it's a not bad study because it's very well done, but it's a low evidence, even level evidence one. So it's a low evidence, and we must be prudent in order to not to say, well, here we have the solution.
Can you use that in stem cells?
Excuse me?
Can you use this in stem cells?
No.
Why not?
No, because you need that the stem cells came from the subchondral bone. If you put stem cells outside the bone, that clot, those stems will not go to its place.
No, I mean it's if you can actually put stem cells on the defect, a preparation of stem cells on the defect, and then cover it with the VST.
I cannot answer you because they have not studied that.
What about the osteochondral transfer? Mosaic class, for example, especially if there is a definitive traumatic lesion of the chondral region in the head of the femur.
I think it's a very good solution. I think it has all sense. And in the femoral heel, when you have an osteochondral lesion, probably is the best solution. Even in limited avascular necrosis that leads to a small area of chondral lesion, even in those cases may be a good solution. But there are two problems. One is that you need live cartilage. That means that you cannot work with frozen specimen. Of course, you need a bank tissue, and you must take from the bone tissue, from the donor, and put in your femoral head. And you need a live cartilage. That means that it must be a fresh allograft. That's very difficult to obtain. In Spain, it's impossible because of our regulations. The Canadians can do that, and in some places in the United States they can do that. If you can have fresh allograft, that means between 10 and 20 days after the death of the donor, then you can do it, because you will have a live cartilage. The other problem is that you have to do an open surgery, of course. You have to do a dislocation in order to arrive perfectly to the defect. And we still don't have enough level of evidence of those treatments to say a patient, okay, we have to do that because it's the best solution. It's a solution that we can talk with the patient and we can explain, and the patient can decide. But it's based on our intuition, not on our evidence. But I think it's a very, very good solution.
Some people have this donor site from the back of the femoral condyle, the knee, ipsilateral knee. Because it is
I think it's not a good solution because those defects are always big ones. It's very strange to find a 9 millimeters defect in the cartilage of the femoral head. I have never seen them. They are always 15 to 20. If you have a 50 to 20 millimeter diameter defect, you cannot do without autograft. You must go to allograft.
Thank you. What is the effect of your tough non-absorbable suture material? What is the effect of your tough suture material, non-absorbable suture material on the femoral side? And how we can know that it wouldn't cut through the acetabular cartilage and it would be just a foreign point or loose point?
Well, for sure it's not the ideal solution because I'm leaving that suture in the articular side. I don't know what it will happen with those sutures in the femoral side, but I know that if you leave a defect in the cartilage, that will give a kissing lesion in few years. So the problem is not if the solution is the ideal one, the problem is that it's the best solution that I have found.
But no second look.
And the second look, it was perfect. But the second look was at 1 year. So it was perfect in order to see that you have stability of that fragment. But I don't know what it will happen with that cartilage in 5 years, and what will happen in the femoral side in 5 years. And when you are treating cartilage problems, You must think in 5 or 10 or 15 years, not in 2 years. If you are just thinking in 2 years, go with the pregnant.
الله يسلمك، ازيك يا عم؟ جود جوب يا حبيبي، كويس. ماشي. محضرين الحالة للدكتور مارك؟
نعم.
محضرين الحالة للدكتور مارك؟
يعني لسه بيصحى العيان.